Welcome to the Swift Healthcare video podcast, exploring the intersection of healthcare and leadership, hosted by Dr. Patrick Swift. SwiftHealthcare.com is your resource for healthcare professionals to find coaching and consulting to engage, restore, and transform yourself and your organization. And now, here's your host, Dr. Patrick Swift.
Welcome, folks, to the Swift Healthcare video podcast. I'm Patrick Swift, and I want to thank you for dialing in, for joining us. I have a special guest, Kellie Goodson, for the show. Kellie, welcome to the show.
Great. Thanks to be here with you today, Patrick.
Absolutely. I think we're going to have a fantastic show. And let me read you folks Kellie's bio here. Very impressive person. Kellie is a thought leader in the areas of person, patient, and family engagement and equity in healthcare quality and safety improvement. She's led a multi-year analysis of hospitals leveraging and deploying patient-family engagement in quality and safety improvement. She has worked with multiple health systems to improve patient outcomes using quality improvement science through the lens of health disparities identification and resolution. Let's not just identify it, but let's find the solution to it as well. Kellie has co-led, listen to this, Kellie has co-led national affinity groups for the topics of patient-family engagement and health equity for who? The Centers for Medicare and Medicaid Services, I think you've heard of them, and has served on the National Quality Forum Committee, including the National Quality Partners Action Team, to co-design patient-centered health systems. Kellie, welcome to the show.
Thanks, Patrick.
I'm delighted you're here. And what are we talking about here, folks? We're talking about patient-family engagement. We're talking about health equity and you. And what that means is that this topic relates to all of us. This isn't just a sub component within what we do with healthcare. It's all of us, whether we're in finance, whether you are in environmental services, helping cleaning the floor, whether you're a physician caring for patients, whether you're a CEO. I'm a CEO who's gone undercover boss, and I've helped clean the floors and wipe down toilets and beds. This is all of us together in the work that we do, right? So in the show, Kellie, we're going to talk about a lot of incredible stuff. And I want to ask you also, just at the top of the show, what are you up to these days? You've done so much.
Yeah, thanks, Patrick. Currently, I'm working at Vizient, which is a member-owned, member-driven healthcare performance company. We've got not-for-profit academic medical centers and community-based hospitals across the country. I've also started partnering with a new startup called Diversity Crew, and that's a consortium of passionate people really wanting to help improve diversity, equity, and inclusion, not only in healthcare, but in all industries. And I also work with a company called ATW Health Solutions. It's a consulting company out of Chicago, again, working in that patient family engagement and health equity space.
Excellent. Well, shout out to all those companies and just kudos for being part of all that. And we're taking a look at patient family engagement and health equity. We could talk about that for hours, right?
Yeah.
But let's break that down for the purpose of the show and just talk about the tools. And I know there are two tools that you're using this work. Can you tell us about that?
Yeah, so I really focus on how to use patient and family engagement as well as health equity in your quality improvement efforts. So, let's start with patient and family engagement. It's known throughout the industry that when an individual patient is activated and engaged and educated about their own healthcare, that they get better outcomes. This has been studied for decades. And I just want to mention Dr. Judy Hibbard, who created what she called a patient activation measure, or PAM tool that actually she created.
What's healthcare without another acronym?
I know, right? But this patient activation measure really brought to light that patients are at different levels of their own, knowledge, education, confidence, and how to care for themselves. So Dr. Hibbard came up with 4 levels of patient activation, starting from sort of that traditional passive, patient that really just receives healthcare, it's more of that one-way street. They just receive the information and they do their best, but they don't really have the confidence to care for themselves. And then it, goes all the way up to level 4, the highest level, where they are their own advocate, and they are really understand their condition. They advocate for themselves. They're looking for the best, medications and procedures and solutions for themselves. So this patient activation concept that Dr. Hibbard really brought out is one of the most researched and most studied patient engagement tools. So it's really brought to light how outcomes can be improved when we activate and engage our patients.
That's so critical, Kelly, because it reminds me of a gentleman I took care of in the 2000s, diagnosed with myasthenia gravis on a neuro rehabilitation unit. And when I first met him, black gentleman in his 30s, and when I engaged him, I asked him how he was doing and what are we doing? What are you doing here? How can we help you, to get his input in his own words. And he said something that stuck with me. He said, what's the point in talking with you about this? Because no one really listens. And he had been misdiagnosed, poorly assessed, and gone through a arduous, horrible journey of not being properly assessed and then treated, and had been completely disempowered. And so my focus when I heard that was to be his best friend, to engage, to get his story, to prop him up, to be engaged and empowered. And what you're describing is these 4 levels in which the one person is the least engaged. And there is a bias, I think we have, of, well, if the patient is not really engaged, then they must not really care about their health. And there is so much we can do to engage our patients and also engage our colleagues to be part of this journey. So this gets to, I love it. I love that you started with that. And thank you for tickling my memory from 20 odd years ago of a patient I was caring for, because this is about engagement. When we engage people, there are better outcomes. There's better self-esteem. There's better health. There's better, quite frankly, joy and heart in what we do in this dyad, this collaboration with our patients and with each other. So let's switch gears to health equity, and how can it be a tool for quality improvement?
Well, I'm going to ask you a question. I'm going to have you put your old hospital CEO hat on and ask.
Oh, I got a hustle here. Okay. All right.
So what would you say if I told you I could find the patients in your hospital that are in the highest readmitted, let's use readmissions, for example, highest readmitted patients. And within that group, I can tell you exactly the subcategories of patients that are highest readmits to the hospital, and really pinpoint who those groups are for you, so that you can, shift your resources and shift your focus to help those patients not be readmitted and really reduce your readmissions overall. Would you be interested in that?
Absolutely. And here's why. On many levels, and if I'm putting on that CEO hat, I'm going to put on my CEO hat. I'm not going to give the standard answer. The standard answer, I think, would be about, well, I'll just speaking for myself. It is about safety. It's about quality. It's about the patient experience. It's about the physician and the provider experience. So from a safety and quality perspective, when you're identifying folks that are, let's call them frequent flyers, who are coming through the door constantly, that's not ideal, because it may be heads in beds. It may be an old bottle in which you've just got people coming through the door and you're generating revenue as a hospital. But that's a zero-sum game, and everyone loses with this fee-for-service, boom, 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 heads in beds. I would be really interested in how you identify those patients, and then how can we serve them and reduce the likelihood of readmissions, right? Cut down on their frequent flyer status. They would get less miles. That's fine. They don't need free tickets. And the benefit to the providers and the organization also is that you're able to serve more people more effectively, because then you don't have people coming through the hospital that are using up resources that we could apply elsewhere. And then we're able to think proactively about prevention, about engagement for staff to be able to be part of these bigger solutions. So, and I could go on, I'll shut up, but really we're touching on safety, quality, the experience, the economics, and quite frankly, doing the right thing for the right reasons at the right time. And what you're touching on is the timeliness, because right now, as we speak, there's someone sitting in an emergency room who's suffering, who's constantly going through this revolving door. And it may be benefiting the system, that they're going through that door, and there can be an organization where they're not interested in helping stop that. But those organizations that are interested in stopping it and cutting down on their frequent flyer status can do better and save lives, save money, use better resources, and do better good. Ad majorem Dei gloriam, to the greater glory, you know?
Yeah. Yeah. And the way we do this.
That's probably more than you, that's more than you,
No, that's
it's more than
great.
you plan on biting off, but you asked my opinion, so.
Well, if we do, what we do is we can, find those patients by really disaggregating our data. So we look at data in the aggregate all the time, and I'll stick with readmissions. So we know that heart failure, AMI, pneumonia, COPD readmissions, those are high rates of readmissions. Patients with those conditions, automatically have these sort of higher rates of readmission than your average patient. So when we disaggregate that data, for example, we can find out, these people from this certain zip code have higher rates of heart failure readmissions,
Okay.
or, when we disaggregate the data, we actually can see what's happening. And I've got a really great example of a hospital system.
And then you identify a solution.
Then you identify a solution. So the hospital system, Novant Health, they're based out of North Carolina. They disaggregated their pneumonia readmissions and found out that African Americans in their hospital had the highest rates of pneumonia readmissions. So they got a group together and went to work, used the traditional PI, QI tools of improvement, and they did chart reviews, they did observations, they interviewed patients, they interviewed staff, and they discovered some very specific things that they could do that would help the African American patients reduce those readmission rates. So not only did they get rid of that disparity in the readmission rate between their African American and all other patients, they dropped their pneumonia readmissions for all of their patients. I mean,
yes. So I love that you said that, because that's a win-win-win.
Win-win-win. And I was really honored to nominate them.
Everyone benefits.
Yes. And they won an award for it. I nominated them for the inaugural CMS Office of Minority Health Equity Award back in 2018. And they were awarded that distinctive award from CMS. That's so amazing. Not only is it a win for patients, it's a win for the organization. It's a win for everybody, like you said.
I love it. I love it. So you're disaggregating the data, you're applying that information, you're identifying solutions. And when you identify a solution, you're saying, and I want listeners to be aware that, Kellie, what you're talking about is when you identify the problems and the solutions to it, then processes can be put in place that are helping everyone, not just a particular slice of the pie, that everyone benefits from this. So I want to challenge folks to be interested in what's going on in your organization. How is your organization looking at health equity? Because there are people, I mean, let's take the Black Lives Matter conversation. I've got friends I love dearly, and they get defensive, saying, what do you mean Black Lives Matter? All lives matter. Well, of course they all matter. But when there are disparities related to Black lives, well, injustice anywhere is injustice everywhere, number one. But number two, there are people suffering as a result of systemic ways we've built healthcare. And so when we solve a piece of the pie in one slice, the truth is that everyone wins. So when we're recognizing that Black Lives Matter, everyone is winning.
Right.
If you want to drive a campaign for White Lives Matter, like what good is that doing? There's plenty of folks, white folks, being a white Hispanic myself, but being a white person, the system is, I'm certainly benefiting from being white. But when it comes to addressing health equity, health disparities, Black Lives Matter, when we address the inequities in healthcare, everyone's winning. So I'll get off that soapbox and go back to you.
Well, the rising tide rises all boats, right? And
I love
we know that. And Patrick,
this is not voodoo economics.
No, not voodoo economics.
This is not George Bush, and we're not talking about voodoo economics here, but we are talking about all boats rising.
Yeah, and this is really what federal, state, and even the CDC has done with the COVID-19 data, right? So they've disaggregated the data. They've showed us the rates for the different populations that we have in our country. And we at Vizient did this as well. And, you know, we have just wonderful, smart data scientists at Vizient. And they took all of our data, it's over 500 hospitals worth of data, and they stratified our COVID-19 data by race and ethnicity. And we found what you're hearing in the news, that Black and Brown Americans have higher rates of not only getting COVID, but being hospitalized for COVID and having COVID, dying from COVID. Yeah. So, one thing that we did, so talk about, sort of disaggregation and investigation, our really smart data scientists also added in age. So we have race, ethnicity, and age. And when you hear about COVID-19 and you think, those over 65 years old are most affected by it. Well, that's true if you're white. But if you're Black or brown, you are more affected by it between the years of 20 years old and 65 years old. So when you really use the power of data to look and investigate and you find things that you can actually do something about.
So what I feel you touching on under all this, under these, still waters run deep, is we're talking about high quality care.
Right.
Because when you're providing high quality care, leveraging the data to find evidence-based medicine, well then, when you're practicing evidence-based medicine, you're leveraging that data to address what the data is telling you, which happens to tell you this demographic needs this attention, this demographic needs more of this attention. Let's be mindful of that and following what the evidence tells you how to best provide care, right?
Yeah. And I have another great example for you, Patrick, just along those lines. Another Vizient member that I've worked with, Harborview Medical Center out in Seattle, Washington, they've been working on this for decades, and they are really sophisticated at this. But when they first started, they went to stratify their data, and they didn't really have great patient demographic data. So that happens to a lot of organizations. They want to do this and they go try to do it. And it's actually not as easy as it sounds. And then the data doesn't look right. And there has to be investigations around data collection and completeness and all that. But I tell them, don't let that stop you. You can still do, work in this area. And that's exactly what Harborview did, 10 years ago. And they were able to find out that, for example, their colonoscopy screening rates for Vietnamese and Spanish speaking patients were way below those of English speaking patients. So what they were able to do by using the data and finding that out, they were able to provide prep clinics in Vietnamese. They would conduct them in Vietnamese and in Spanish, and their screening rates went way up and closed that gap. So that's another example, and that is in 100% in control of a health system. A lot of times health systems are asked to do like big things, like build a farmer's market or subsidize housing for patients. Yeah. And it's so intimidating. And they think about it, they get in that plan phase and they just kind of spin their wheels and they think, how are we going to do this? It seems so huge. And I always try and really just bring them back down into what they can control, which is the data that they already have, the patients they're already serving, and the processes that they're using to take care of those patients.
Kelly, I love it. And I have to chuckle. For those watching, I've laughed when you touched on the farmer's market. And the reason is that there are organizations that will build the farmer's market just so they can look like they're trying to address community concerns. And that's wrong. The notion here is that if you're going to build the farmer's market, by God, you've got to be taking a look at what Kelly just spoke about the data, about how services are being provided, and then being smart about how there is a strategy and plan in place to identify the problems and then identify the solutions, including making a farmer's market. I want to shout out to Newark Beth Israel Medical Center in Newark, New Jersey, near and dear to my heart, and they've done it right. Yes, there is an amazing farmer's market, but it's more than just the farmer's market. It's about doing the right thing at the right time or the right reason and collectively having a good strategy in place, right?
Right, exactly.
Yeah. Yeah.
You know, what I want to say too, Patrick, is,
Yeah.
you know, a lot of people think this is new. This is new information. Wow, these patients, our minority patients, are not, having good outcomes here. This is not new. This has been very long time coming for this to be put in such a spotlight now, and I'm glad it is. But back in the 80s and 90s, even our own Health and Human Services commissioned reports around looking at health disparities. And everybody knows about the IOM reports, To Err as Human and Crossing the Quality Chasm, and just shined a light on how our quality in the United States is not up to par with other countries. And so that was really the first time it was brought into the public that, hey, maybe our US healthcare system isn't as good as we thought it was. And equity was brought up in those reports early on. And we've worked really hard as a healthcare system on the 6 aims that they set forth for us. And equity was one of those aims.
Yes.
But it really, those of us who have been working on this for a while call it the forgotten aim. So until COVID came around and we really started seeing these disparities in an active situation, people didn't understand that these disparities exist.
Mm-hmm. And this applies not just to the US, but around the globe, right?
Mm-hmm. Yes, I mean, it's everywhere, unfortunately. In some of the systems that we have in place, some of the traditional, especially in America, some of the things that the policies and even just access to good housing and education really affects our minority patients, and it manifests itself in these clinical outcomes.
Kellie, applying this on a global scale, I'm curious about what's the most recent research on disparities that may be specific. Your data may be US centric, but it also parallels what we in your heart we know is happening on a larger scale, right? Mm-hmm. But can you touch on the more recent research?
Yeah. So the Agency for Healthcare Research and Quality puts out an annual report, right? It's a disparities report. And I think that's been done for the last 15, 16 years. So if you look at that report, you will see that they study 250 quality measures in that report. And fully 40% of those quality measures, which equals about 100 quality measures, that Black and Indigenous people of color receive worse care than white people in that many measures. So 40%, which is 100 measures. I mean, this has been going on for a long time. And it's even things like the timely administration of medication for a heart attack. So Black patients don't receive the right medicine in a timely manner when compared to white patients. We can all do something about this, right? That's where, when you talked about that this is about all of us, it really is.
And Kellie, I want to add, I'm familiar with some of that research, and that the research I've seen in the studies, they've controlled for level of education, socioeconomic status, employment status. So even, for example, addressing pain management for broken bones or pain management during labor and delivery, when you statistically control for a level of education, socioeconomic status, employment status, when you pull all that out and just compare apples to apples, we're seeing in the data that there is a difference in care. And that's at the core of what we're talking about here. If we're not practicing evidence-based medicine, these kind of disparities can exist.
Exactly. And when
we do, the right thing happens.
And when we do, the right thing happens. When a patient is lying in a bed, you don't know if they're a CEO of a company or if they're part of the janitorial staff. Like, you don't know who these people are in your bed unless you take the time to get to know them.
Shout out to EVS. Shout out to the janitorial staff. They're the tip of the spear when it comes to infection control and addressing COVID. So shout out to EVS. Go on.
Absolutely. So, it's just, this is, of course, near and dear to my heart. My husband's an African-American man, and I want him to get the best health care that he can get. My children are biracial. So, this is really, at the heart of what we're doing is treating humans as humans and giving everyone the best care possible.
Absolutely. And the data you touched on, is government looking at disparities. Mm-hmm. So what about in the healthcare system perspective? What are they doing? What's the latest?
You know, it's interesting because healthcare systems do have what they need to do this. I gave you examples of Novant Health and Harborview Medical Center. And actually, and you mentioned at the top, I led a affinity group for CMS around health equity, co-led that with the New York State Health Foundation. And we got a big group of people together, and we created what we called a health equity organizational assessment. So it looked at 7 categories of data collection, data, collection training, validation, data stratification. We looked at the cultural and organizational structures in place at hospitals to see how prepared they were to identify and address disparities. So we had over 2,300 hospitals participate in this HEOA, Health Equity Organizational Assessment. And we found that although they collect the data, they really don't validate it. When they do stratify it, they really don't know what to do with it, and they don't really communicate about it. So there's a real need here for hospitals to just start digging in and doing this. It's something
They're afraid.
They're afraid.
Kellie, they're afraid. I've sat in the boardroom. I've sat in these conversations, and it's a political conversation. It's a challenging conversation to collect the data. And then the fear that people have over recognizing, well, what if the data shows that we're not doing a good job? And then how do we manage that? Number one, the feeling of powerlessness, what to do. Yeah. And there are things that can be done right now. And perhaps it may not be in-house. And that's part of it, is organizations considering getting help from outside counsel, outside support, to get some input on what to do with the data they've collected, the information they have, and for example, the kind of work that you do, Kellie. But so how can they address, in addition to the excellent kind of work you do, what are the barriers they can tackle to address these problems?
Yeah, so, what they need to do is they just need to get started. Stop spinning your wheels in that plan phase, take your data, do the analysis, and don't be afraid of it. I mean, if anything, now is the time to do this.
Absolutely.
Right?
I know I say that word a lot, but I mean it. This is the time to do it.
It is the time to do it. And look to others. Like, I'm going to give another example. So
Please.
Rush University in Chicago. They posted their equity report. They called it a health equity report. And they have this beautiful report that lays out all the disparities that they found. So just do an online search.
That's bold and brave.
Very bold, very brave. It, to me, is the gold standard of what all hospitals and health systems should be looking at.
Ooh.
It's amazing. I cannot say it enough. If I had a magic wand, I would wave that around and have that be a requirement, just like a CHNA, or maybe becomes a part of the CHNA, the Community Health Needs Assessment, that hospitals have to do every 3 years. It's truly amazing.
So if you work at Rush, you can be proud and celebrate that, and hashtag it, celebrate it, kudos, great job. And if you don't, take a look at your organization. And I don't care if you're in the C-suite, you're at the VP or director or a physician, or working in finance, or working in environmental services, or working in nursing, or working in physical therapy. It goes on and on and on. It doesn't matter where you are in the organization. Take a look at your organization. Is it doing something like that? And if they are, please, for God's sakes, say thank you to the leadership. And if they're not, pay attention. Mm-hmm. And is there another organization in your town that's doing the right thing, that aligns more with these kind of values, that is doing the right thing for the right reason, the right time? Then maybe that's somewhere you want to be working, because they're really valuing not just the dollar, not just the business of healthcare, but they're honoring the practice of caritas. They're honoring the practice of caring for human beings, caring for other human beings. And I know you would resonate with that kind of language, right? Right, Kellie?
Yeah, very much so. I mean, this is just humans taking care of humans, and it's as much of an art as it is a science. And I just think now is the time. If you've been afraid to do this in the past, Do it now. Engage patients and families, invite them into your organization through PFACs. And then, take a look at your outcomes data. Just pick one, pick readmissions. I promise you, you will find something in readmissions, but you could look at your care for diabetic patients, your care for hypertensive patients. You will find some things, that very specific things that you can fix. I promise you.
Love it. Love it. Kellie, my favorite question to ask my guests is, if you were standing at the top of the world and you had the attention of all the healthcare folks, the docs and nurses and finance folks and everyone who works in healthcare, and they looked up and you had their attention and you could say something, what would you say to them?
No, I think first I would say thank you, actually. This has been such a trying time for everyone. And, healthcare professionals truly are our heroes. It's so hard. And when we say these things and we talk, we know this is not easy. We know this is difficult. So as Patrick said, reach out for help. We're all going to try to make this better for everyone, not only patients. And we want to reduce disparities, but we want our staff to find joy in their work and meaning and be happy. So I think I would say thank you, and that we know this is not easy, and we are here to help.
Amen to that. You are here to help, and I'm grateful for all the work you've done with the work you've done with CMS and the PFACs and on the national level, and you've been inspiration at international conferences. So what you shared here, you've been sharing in conferences. I've been touched by your leadership and really appreciate your thought leadership on a global scale, because your principles and practices are models for how to think about what we do, but also how to feel. Connect to why we're doing what we do, and then be empowered to make that difference, Kellie. So thank you. If folks were interested in following up with you, how could they go about doing that?
I think the best way probably is through LinkedIn. I do have a page on LinkedIn, and that's probably the best way to get in touch with me.
Okay. Well, I will include that in the show notes. And gosh, Kellie, we've covered a lot of topics here, a lot of ground, and learned so much. So I just want to say thank you for being a guest on the show, all you share, the heart and passion for what you do. And I'm grateful for your being a guest here.
Thank you for having me, Patrick. It's been real fun.
Thank you for listening. Please subscribe, rate, or leave a review about the show on your favorite platform, and learn how to support the podcast as a patron at swifthealthcare.com, where you can also find the show notes and all of our episodes. Thanks for joining us.